All right, hello and welcome again to another Down Fracture podcast, a podcast for talking jaws. Downfracturepodcast at gmail.com. If you want to email us any feedback, any suggestions, any cases, try to keep the ridicule to a minimum unless it's purely directed at Sam, which we all appreciate.
I do
Otherwise, Dr.
appreciate that.
Michael Wasson here with Dr. Sam Bobek. Sam, what's going on, man?
Not much. Thanksgiving next week. Just kind of prepping my kids to put them in work. Who's doing the turkey and the pies and whatnot. Do you have your kids making food yet for Thanksgiving?
And my kids can barely tie their shoes.
Time to get it going.
I guess
Make some
so.
cranberries.
Plant the seed early and watch it grow, I guess.
Yeah, no, yours flying by.
They do. Well, per usual, you and I, but today we have what I would describe as an esteemed guest. Would
Yeah,
you describe him as such?
absolutely. Yeah, I was really looking forward to this. This has been on my calendar for a bit. I was excited to talk. We talked a little bit before this, but look forward to the hour discussion we're about to have.
Yeah, so we're joined today by Dr. Lou Mercuri. Lou, I and Sam, we kind of talked beforehand and we know about you, but do you mind telling the rest of the world, all of our vast listening audience, a little bit about yourself and why you would be interesting to talk to, I guess?
Thanks. Thanks for inviting me, and it's fun to do these kinds of things. For those of you who don't know me, I'm Lou Mercuri. Um, I practice oral and maxillofacial surgery, full scope, in an academic environment for about 45 years. When I retired from practice, I was really interested in research, and fortunately got invited to join the orthopedic surgery department in the research unit at Rush University Medical Center here in Chicago, as well as the biomedical engineering department at the University of Illinois here in Chicago. So for the past 13 years, I've been involved in material science research, trying to put some science behind the temporomandibular joint replacement device that I helped develop for Stryker TMJ Concepts. And it's been a fun ride, and I enjoy talking about it. So the guys gave me this opportunity, and let's get going.
Yeah, I mean,
Yeah,
that's great.
let's do it.
I mean, I feel like I got introduced to you on outside of just reading your papers through the email group. Did you start that around 2013 then?
Yeah,
That
that was interesting. I've been a consultant for Stryker TMJ Concepts for years, and one of my jobs as a consultant was to review the literature in on TMJ, because the
yeah.
FDA requires each company to keep up with the literature. So my job was to do the literature, and I thought, this is an interesting exercise, but a lot of other people could benefit from this, and so that's how it got started.
Yeah, so for people who don't know, if you have interest in joint replacement or TMJ replacement, or you practice in that world, you can get added on to this group and you get information. It's really helpful. You get updated papers. I mean, honestly, Lou, you send 2 or 3 emails a week probably. I feel like it is a constant resource and honestly one of the things I keep up with the best. And so I can just tell you, thanks for keeping me up to date with all the new literature because I don't read orthopedics, I don't read certain journals, and it's easy to get siloed a little bit on the information.
Yeah. Well, I'm I'm learning a lot about orthopedic material science research. Not having no engineering background, it is an interesting and time-consuming job,
Yeah,
but it's fun. It's fun.
yeah. So, because the story of TMJ replacement, because you were there when everything was, for lack of better words, when the shit was hitting the fan in the 70s, 80s, and 90s, which, we still hear about today, right?
Yeah.
Um, and I see that as it was oral surgery, not reading the other literature. But as someone who lived through that, can you like talk us through a little bit of that, or how you was practicing during the Teflon and the different prostheses that didn't work out, the whole Bitech business?
Yeah. Well, I trained under Dan Laskin. and I did my master's in TMJ. And so I sort of slotted myself in my career in TMJ. Um, I started seeing when I went to the Medical College of Virginia, where I was for 10 years. I got interested in uh, disc displacement. And so I ended up going up to Minneapolis and spent a week with Clyde Wilkes, watching him do disc repairs and all this stuff. So I came back to Virginia and I did about 400 of them over about an 8-year period.
Wow.
And then I followed up on these patients and they were doing terrible. Many of them had joints that just looked awful or they ankylosed. And so now I'm thinking, I got to do something for these people. So at that time, the only thing that was available was the Kent Vitek.
And
Uh,
you're talking about like late 70s, early 80s right now. Is that
yeah,
what you're, and
yeah.
you were mainly taking discs out and putting fat in, or what were you doing with the disc?
No, we're doing disc repairs.
Oh, just like
Yeah,
plication?
just tying them back. Yeah,
Okay.
just tying a disc back. I mean, that was Clyde's big thing.
Yeah.
So do you mean disc repositioning, displication? You're not talking about like trying to resuture the disc if there's a perforation. You're
No,
not talking
no,
about actual like trying to repair the disc. You're talking about plication.
right,
Got
right.
Got
it.
it.
Disc
Okay.
plication, right. Um, Terrible. Patients didn't do well at all. And when I followed him up for, after 8 years. So I said, well, I got to put something in here. And I had really bad results with rib grafts, both in kids and adults. Kids, they either ankylosed or they way overgrew or they didn't grow at all. So the only thing available was the Kenvitech. So the problem with that was it was covered with Proplast.
Yep.
And so what I would do is I would scrape the Proplast off it before I would put it into a patient. But
Hmm.
these patients, many of them, and as well as the Proplast Teflon patients, their anatomy was completely destroyed. So it was really difficult to put a stock device in. Uh, so one day, a couple of salesmen came by the office and said, this was when I was back here in Chicago at Michael Reese, and said, we're real interested in developing uh, a dental implant. And I said, well, okay, I'm sort of interested in that. But the one guy said, I'm leaving the company and I'm going out to California and work with this orthopedic company that makes custom orthopedic devices. And I said, could they make a custom TMJ? Because I was really having a lot of problems with these stock devices. And they said, well, I don't know. Long story short, I got involved with this company called Techmedica and sitting at I can still remember this, sitting at a lunch table, um, we drew out on a napkin kind of a design of a TMJ device. And after working through it and all this kind of stuff, we came up with a design for a custom TMJ device. And so that's how it all really got started. Uh, the Proplast Teflon thing was really the linchpin for this.
Well, because I understand that most people realized it was going bad pretty early on, but it still took a while for things to for everyone to kind of change their practice. Was that just because the communication wasn't the same? Because we don't have like, you don't have texting or chat groups, like you just had to meet. Is that what was the delay on the standardization of the turn away
Well,
from Proplast and
well,
that last?
everybody thought that Jack Kent was doing the right thing. He
Yeah,
was helping us out. Um, Everybody thought that this displacement was the whole answer to TMJ. And if you took the disc out, what could you put in?
yeah,
You could either put the Christensen fossa eminence device, or you could put in Proplast Teflon. It didn't make much sense to do the hemiarthroplasty or the Kent, the Christensen fossa eminence device because you were pitting metal against bone,
yeah.
which is a nightmare. So people gravitated to the Proplast Teflon, and there was a lot of literature on the positive side that came out of LSU and places like that, South Carolina, and so uh, and then it took people actually looking at patients over a long period of time, and then finally the FDA to come out and say, this shouldn't be done.
Because
And the
there's like a
interesting thing,
15 year, it took like 15 years or something, right? Like
yeah, it took a long time. And
that's a lot of practice.
the interesting thing is that back in 1964, John Charnley, who was an orthopedic surgeon in England, had experimented with Teflon in a hip prosthesis. And he wrote in the Lancet, and I have the article, that this material should never be used in any joint. Yet, here we are in 1980s, and we're putting it in. Now, how did the FDA approve Proplast Teflon? Well, it was approved because there's a 1976 uh, um, statement from the FDA that says if you can prove that something is substantially equivalent to something else, it doesn't have to go through a process. So Holmesy and his group made Proplast Teflon substantially equivalent to silicone rubber, which was used in joints, which now shouldn't be used in joints
Yeah,
either.
yeah.
Um, and that's how it got approved. And
Got
so
it.
it took that whole process, all those years, to get undone.
And so you drew from your experience with doing the surgeries, and you met up with this company, it's Tech Medica. Am I saying that right?
Medica, right?
Tech Medica, because that predated TMJ Concepts, which ultimately was purchased by Stryker. But Tech Medica, and they brought their orthopedic um, experience. Because I mean,
Yeah,
the Concepts device is a solid device. I mean, it looks like a hip or a knee, like it
right.
just it seems the same. And it was really you guys just penciling it out that brought it about.
Yeah, we said, these materials, the ultra high molecular weight polyethylene, the chromium, cobalt, molybdenum, had the titanium, were all used in orthopedics, and they'd been
Yeah.
used for like at that time, 30 years. So if they work there, it ought to work here. And we also felt that with a custom device, because the interface between the host bone and the device was so good that number one, it should be easy to put in, and number two, it should last longer because you won't have micromotion that occurs with stock devices. So that was our calling card. The other thing that we felt was important was that the polyethylene, ultra high molecular weight polyethylene bearing surface on the fossa should have a metal backing because ultra high molecular weight polyethylene has property of what's called cold flow or creep. And if you don't back it, like all orthopedic devices are backed by metal, it's going to flow. And what we've seen with some of the stock devices that have an all polyethylene fossa is that it cracks right at the junction where it has to make that turn around the zygomatic arch, and they fail that way. So we felt that was extremely important. And so we started and we developed eight centers where we did a prospective study that we published in 1995, which was the basis for our PMA, because TMJ devices are considered class 3 devices. It's just like a heart valve, um, mainly because of the Proplast Teflon issue.
Yeah. Yeah, no, I mean, recognizing the error with the devices as they were going on and coming up with an alternative device that really was solid. I've been impressed with because it hasn't changed materially in the last 35 years. Like the
Yeah,
device itself, it's pretty
it
much
was,
the same.
yeah, it was approved by the FDA in 1999. So
99.
we're talking about what, do the math.
Yeah. So,
27
I mean,
years,
26 years FDA
26
approval.
years. Yeah.
But I mean, during development and the rest, there was some lead time where you guys were figuring it out.
Yeah. I put the first one in 1990.
Yeah.
Um, and then we had the eight centers that followed up.
I'll put a shout out to the posterior lip. The posterior lip is great.
Oh,
I
absolutely.
mean, that is a key feature to the device, especially advancing the mandible. I know you know all this, but just for the listeners, posterior lip on the fossa is such a big difference in between the two devices that exist in America. It's hard to really overstate that. So I really appreciate that, guy. Was that part of the original napkin?
Yes.
Nice.
Not because I think it was just luck that we said, all right, I think one of the engineers said, you need to have something in the back here so it doesn't slip backwards.
Yeah.
Never
Yeah.
thinking about the fact that for orthodontic surgery, it's really important to have that posterior lip.
Yeah. And you were printing it with like some of the original 3D printers at the time then, because 3D printing wasn't like, because
No, it wasn't 3D printed. This is a
It's still
story.
not.
No, no, no. And
no, not the device, but the onto the skeleton, right? Because you use 3D printers to print the skeleton to make the device onto, no?
no, no.
Well, what'd you do?
What?
This is crazy.
There was a guy by the name of Malcolm at the company, and what he would do is he would take the CT scan cuts and cut them out and pile them up on a stick. Okay, so he made a layered thing, and then he would use clay to make the
He would like the actual like the printed CT image. Is that what you mean?
CT image. He would cut and put in a stack. He would stack the images,
Okay.
and then he would use clay to make the fossa, the skull and everything. And I mean, these were really, if you saw the original devices or the original models, I mean, they were really archaic.
Yeah, I bet. I mean,
But
Sounds
because 3D printing, I always assume that's what happened. That was like
no,
in the early 80s, right? Like didn't Whole make the initial printer then? But that's not what you guys were using, huh?
no, not at all. And Malcolm, I mean, he was a real artist, and he did other things. I mean, he was a sculptor, and he worked on cars, and I mean, he's this guy with a big white beard. I mean, he was a really interesting guy,
Huh. That's
and
awesome.
yeah, that's how it was done.
Sorry, Wasson.
Now I mean, it's all stereolithic, 3D printed.
Did you
Not,
guys did you switch in the 90s? Rough.
it switched in Techmedic was sold.
Yeah.
Techmedic was part of Sulzer Medica. Sulzer Medica got out of the medical business because they make trains and gondolas in Switzerland. But it was sold then to Ansbach. It was an orthopedic company in Florida. Uh, Ansbach bought all of the things from Techmedica. Techmedica also made a plate and screw system that Bill Arnett had developed. I don't think many people ever saw that. I mean, it was kind of a flimsy thing. So they sold that off to Zimmer and the money they made on selling that off, they put into developing TMJ concepts.
Got it.
And then the guy who was the president of TMJ Concepts had worked for Techmedica, and then all the guys came along, and he built the company and moved to Camarillo, California, and then after that moved to Ventura, where they are now, and then were gobbled up by Stryker.
What? How long did it take you using that device before you were on board with you were doing the right thing? You said it took a little delay on the original
Yeah.
device because I mean, John Kent's not a bad guy. He was trying to help people out. When did you think this is actually working out pretty good?
About in the middle of our multi-center study, seeing the data starting to come in and crunching the numbers and everything, patients were doing really well. Now we were dealing with some really difficult patients because
Yeah.
the majority of those patients were patients who had suffered the Proplast Teflon issue. And I thought, man, if these people can get through that and this and come out on the other side doing well, then we probably have something here.
Okay. So in your first 10 years or so, and I mean, since then, I mean, the data has just continued to show that those devices do great. Like it's really a remarkable thing, actually. So
Yeah, I think the important thing, and I was talking to the guys out there recently, how do we tell people or prove to surgeons that this is a worthwhile thing to be thinking about? And I go back to John Charnley, and John said, as he got older, he said, the modern practice of orthopedic surgery would be impossible without alloplastic devices. I mean, you don't know an orthopedic surgeon who doesn't do knees and hips who has a successful practice. I mean, yeah, there are people who do hand and that kind of stuff, but they depend on this. Well, Peter Quinn and I have been good friends for years, and Peter developed the Biomet Zimmer Biomet device, stock device, and we've known each other for years, and we both have agreed that the modern practice of oral and maxillofacial surgery should be impossible without the use of alloplastic devices. I mean, how do you handle a patient who's had multiple surgeries, who has destroyed anatomy, or hasn't? The two cases that really get me are, the surgeons who say, I want to do a rib graft for a patient with ankylosis, or I want to do a rib graft for a patient who has high inflammatory arthritic disease. Well, first of all, in the first case, when you have a ankylosis, you're putting bone back into where bone wants to grow. I mean, that makes no sense. The second one, I talk to my orthopedic colleagues, and they laugh at me when I tell them that there are surgeons who want to do rib grafts for patients who have rheumatoid arthritis. They say, you're putting bone right back in where that pannus wants to eat it up. Yeah, this is what they do. So, I mean, those are two minor incidents well, I shouldn't say minor, major incidents where, we should be using alloplastic devices. And now what we're seeing more of, and I think you guys will agree with this, is that we're finding that some of the orthognathic surgery that we're doing, when we're counterclockwise rotating the mandible, bringing the mandible forward, when the condyle has been compromised in some way, either by a resorptive process or a degenerative process. If you do a sagittal split and shove that proximal segment back with the compromised condyle, how long is that going to last?
You're speaking our language, Lou.
yeah, no,
You're
absolutely.
speaking to the right guys here. We fight this battle and talk about this all the time.
Because I mean, it is a hard thing though in practice because you want to be doing the right thing, right? And you want to keep an eye on your outcomes, good and bad. Because constantly questioning what you're doing, whether or not you're doing the right thing, I think is the right way to practice surgery. And I think over time, it's just become more obvious that big counterclockwise moves in condyles that are non-existent, or even if they move reasonably well, but there's not much condyle, is that really going to withstand a 3-4 centimeter movement? And it just kind of is silly. You're like, wait, of course this is going to resorb. But we talk with patients about it, and people are still scared of these things. They're more accepting of resorption post-op than they are of having the devices, because the devices, from a patient side and from a provider side, may mean more surgery. What do you think? Like,
What, that's the argument, the
yeah,
longevity. How long are these things going to last?
yep.
Um, I saw a patient just recently who I put one of these devices in 30 some years ago. And she's still doing fine.
And
Now,
this was on the clay modeled
yeah,
CT
this
cuts,
is the
right?
old device. Okay, this is the old. And she's doing great. She's now having her knees done and her hips done, and I mean, she's an older woman now. Um, but I'm not saying that these devices are all going to last 30 years. Larry Wolford has a paper that he's written where he's followed some of his patients more than 30 years, and he's because he was part of that eight center project. So he has patients in from a long time ago. He's got the original Tech Medical devices. And um, so, do we think they're going to last 30 years? I don't know. But one of the things that we're seeing in orthopedics um, is that younger people are saying, do I sit here and put up with this pain in my knees or my hips or my shoulder or my elbow? Um, or do I consider having this joint replaced? Understanding that in the future, I may have to have it replaced again. But it comes down to, and I used to talk to my patients about this a lot, particularly the younger patients, is quality of life. Okay. What what is your quality of life now? And are you willing to wait until you're, 60 years old to have this done? Or now that you're 35 or 40, do you want 25 more years of a good quality of life? So I think that's a real important point. And one of the things that's really big now in orthopedics and should be getting bigger in our field is patient-reported outcome measures, PROMs. Um, and as we apply those in orthopedics, what we're seeing is that it's more important what the patient thinks and their quality of life than what we think. And as a short little vignette on that, um, there's a paper that came out in the orthopedic literature about um, patients in India that have knee replacements. They wanted to look at their metrics in terms of the surgeon's metrics, how they measured success, and then how the patients measured success. So the surgeons measured their metrics, how the angulation, how much they could move their knee, and all the numbers that they do. And they found that these patients did exceptionally well based on their metrics. But then they did the PROMs on the patients. And the patients said, this is the worst thing I ever did to have this knee replacement. And they said, well, wait a minute, you're functioning better. But no, I'm not really functioning better for what I want. My value is I have to squat to wait for a bus. I have to squat to go to the toilet, and I can't do it because I can't flex my knee enough to be able to do it comfortably. So what we measure as MIO and how much hard food you can eat and all that kind of stuff, that diet and MIO and that is a whole different thing than what the patient is is
And
interested in.
you saying that, it seems silly that we focus on that. But I mean, I'll be honest, I focus on that just like anyone. I want to hit a certain number on opening.
Yeah,
I want their occlusion to match up. I also want the patient, if I walk in the room, how you doing? For them to say I'm doing great. I'm back to eating the food I want. Which arguably that's more important than any of the numbers. So
yeah, absolutely. I think we need to start, I'm not saying that you shouldn't be looking at MIO and you shouldn't be looking at occlusion,
yeah, yeah.
but that shouldn't be the only measure, and that shouldn't be the strictest measure that we use to say this is working out well. If you look at our studies, we showed that quality of life increased in these patients by 87%. And when we asked those patients, would you do it again? Absolutely, I'd do it again. Do you have pain? Absolutely. I still have some pain, but it's decreased. And that's a whole other issue, the
And,
pain issue.
and you were operating on the people who went through those devices before you. I mean, there was probably some primary TMD, like fracture dislocations and new ankylosis patients, but a lot of that data I interpret it to be people who have been through three, four, five, six, seven surgeries. Is that
Yep.
is that right?
Yep. The average number of surgeries my patients had was 5.2 before they came to see me.
That is wild.
In an initial study that I did, which we could never publish, the first 60 total joints I did, I looked at what was your initial complaint. 66% of those patients who had had an average of 7.5 surgeries, okay, was not a due to the joint. It was like myofascial pain. I had a headache. I had a clicking joint that the surgeon said I could fix for you. And they did disc repairs, they did rib grafts, they did orthognathic surgery, those kinds of things. And I can't tell you the number of redos of orthognathic surgery we had to do. And I'm sure you've seen this now
Sure.
because people have been whittling on the TMJ.
You said some things in there that I want to kind of, because we do have residents, we do have young surgeons, and I'm sure we have some patients out there. And I think you hit on some points that I think are worth kind of reiterating or making very clear to people out there. And one of the things that I've done in my practice the past few years is kind of similar to what you're saying, is like at the 6 month and 1 year when I usually see them, I always ask them a series of the same questions of, would you do this again? Just quite frankly, knowing what you know now, would you do it again? And would you have done it sooner? Would you have done it later? Would you have rather postponed? And then I kind of, sometimes I'm not as good with the last one of like, hey, how long were you in treatment before you even got to a surgeon? And I've only had one patient who was kind of unequivocal about would you do it again? And that was because of chronic pain. Their function improved from like an MIO of 14 to like 33. It was a heterotopic bone ankylosing, partial ankylosis case. But they'd been in treatment for over 10 years and had chronic pain. And so their pain problem was their main motivating factor to undergo treatment and especially surgery. And then that wasn't completely resolved. And so they were a little bit, like ambivalent towards it. Yeah, I'd probably do it again because I can chew better, I can open better, I function better, but I still have pain. And I think that's important for everyone to know is exactly what you guys have both been saying is the patients that we have the most data on for the success for these prosthetics are patients who were the worst possible patients to get data on. Like they were multiply operated, they had giant cell, massive inflammatory reactions, destructive anatomy from these devices, and your outcomes were still great. And I think that's kind of marking and maybe you can speak to this, Lou, is the trend seems to be put these in earlier and earlier in patients. We found the data over the years, and this better than I do. The fewer surgeries the patients had, the better they do is with regard to pain, function, quality of life. The surgery becomes harder, the risks go up, all of these things, and yet there's still this kind of, especially from what I see in my practice is the dental community of like this fear that we're like butchering patients, and it's like we see, again, one patient who was unsure if they would do it again, and everyone else is like, absolutely, I would do it again, and I would do it sooner, and I wish I was in treatment for less years. But we still kind of see that pushback. Is that fall in line with the ProPass Teflon thing? Have you seen that in your career to where you can speak to why we have to fight these uphill battles to try to say these are not only not disastrous ideas, but they may be our best, most predictable option for solving the problem in these patients.
Yeah, we tend to repeat history, in a lot of things. This is the same stuff that Charnley went through when he developed his hip prosthesis, and there were a few other devices before his, but they failed, and so he developed something that did work, but he got a lot of pushback from his colleagues, and we've had a lot of pushback from our colleagues, and the ProPlast Teflon thing really put a black eye on anything alloplastic going into the TMJ area. The other problem is that we still don't really understand the temporomandibular joint. My whole thing in my whole career has been, why would we have one joint completely different than every other joint in the body? Okay, that doesn't make sense. So now that I'm involved with orthopedics, I, I've sort of taken the orthopedic approach to, when do you put a device in? Um, do you whittle on the joint for a while? They inject a lot of viscosupplementation things into knees and hips now to put things off, but they don't open the joint. Okay, they don't whittle on the joint. What I hear from our colleagues is, I'm going to save you um, having a joint replacement. I'm going to go in and I'm going to whittle on your joint, or I'm going to do what we call an arthroplasty. What orthopedics calls an arthroplasty is a total joint replacement. But so I'm going to whittle on your joint. Well, as you said, we know if you've had 0 to 2 operations and you do a total joint, you're going to get 75% excellent result. If you have, 3 to 9, you're going to end up with about 50%, and you have greater than 9, you're going to have, 25%. So, uh, I sort of am pushing to the point where I'm saying, if you're thinking about a joint replacement, maybe you ought to seriously discuss it with the patient or send it. This is the other thing I'm sort of big on, is if you as a oral and maxillofacial surgeon or plastic surgeon or ENT never do joint replacements, then don't pick a patient and do a joint replacement. Send it to somebody who does. Because what I'm seeing with complications is, the fewer the number of surgeries that someone does, the greater the potential for complications.
Sure.
Be it orthodontic surgery, dental implants, but certainly with TMJ replacement. And there are plenty of studies in orthopedics that show that it depends, complications depend on 2 things: the skill of the surgeon and the device that they're using. Those are the 2 big things. So the more you do of something, the better you are at it, and the better the devices that you use, the better results you're going to end up getting. So doing the right thing at the right time for the right patient, the right way, is the answer.
Makes
Yeah, no,
sense. Yeah, I think there is this kind of push to, or the trend, maybe is the better way to say it, of if you fail arthroscopy, like to me personally, my practice, if a patient fails arthroscopy, I'm at least discussing total joint replacement. I may not recommend it. We may not go to it. But I kind of feel like those patients who kind of fail some of the initial treatments, they're on that trajectory. Like, hey, you're kind of on this trajectory to where the non-surgical stuff didn't work, the minimally invasive stuff didn't work. Like, we have to at least put this on your radar of maybe we try an open arthrotomy, an open arthroplasty, or meniscectomy or something. But like, you kind of seemingly are on this pathway, and we can consider this as an option. Sam likes to do like 3, 4, 5 surgeries before he even brings it up.
yeah, I'd
But
like multiple stage long term. No,
but I tend to, I've evolved in my 11 years of, it used to be, arthrocentesis, and if that doesn't work, then arthroscopy, and if that doesn't work, disc repositioning, and if that doesn't work, disc out, and if that doesn't work, total joint. Like it was the fourth, the fifth, and like it was an attitude of let's be intentionally as minimally invasive through through the whole process instead of let's be definitive as soon as possible in the process. And I think I've evolved with practice in that I tend to try arthroscopy as much as possible. And then when that fails, I'm really like meniscectomy or total joint. And that's like my talk. And I usually have that talk with the patient and they decide. Is that kind of consistent with the literature, what you're hearing from other surgeons?
Yeah, and to put some science behind some of this, um, in the orthopedic literature, there's a question of at what stage of arthritic disease do you do a joint replacement? And as I said earlier, they've come to the conclusion that the earlier stages are better because the outcomes are better. And we've noticed that with TMJ replacement as well. The earlier stages of the disease, you replace the joint, the better that is. Now, why is that? I mean, what's the pathophysiology behind that? And what they're finding now is that when you put a joint replacement in, be it an appendicular joint or the TM joint, you get a new capsule and synovium that develop around that joint. And we've shown that in some of our studies and with some of the people overseas, we've done the histology on that. And you get synovium, and you get a little bit of synovium that develops in a total joint replacement. What happens when you have arthritic disease um, is that there are two types of macrophages, uh, M2s and M1s. The M2s are the ones that destroy tissue. Okay, they're the ones that predominate in the early stages of arthritic disease. And then the M1s are the ones that repair. They like to repair things. Well, what they found in orthopedics when they looked at the histology of the neosynovium around their joint in patients who had stage 4 arthritic disease in the knee, there's a preponderance of these M2s. They stick around. And that may be the reason why patients who are long-term late stage disease that get joint replacements don't do as well as patients who get it early on because of these preponderance of these macrophages. So it's an interesting study that we're looking at how we can reproduce that in animals now, but that may be one of the keys to it.
Yeah, I think if anyone's doubting the earlier joint replacement in the TMJ world, I would just invite them to look at patients with ICR and who have, especially the ones with no pain. And because of their large open bite or class 2 discrepancy, they undergo total joint replacement as their first and often only procedure with or without orthognathics. And they just do so well. Like they just
That's really
thrive.
remarkable, by the way, because
Yeah.
that would echo what Wasson's saying. I mean, it took me a little bit to get on board with it because when I trained, it was very much like you don't want to hurt people, so let's not do joint replacement unless it's the absolute last thing possible. And even in fellowship, it was still up in the air what the right sequencing was. But putting patients through it and hearing patients and seeing how they do, it's just changed my opinion on that topic. People seem to do predictably well. It's by far the most predictably good TMJ surgery. Just is. And I mean, arthrocentesis, scope, open surgeries, I understand those are good things. It's just there is a little bit of some people don't do well with this. But TJR, if you meet the criteria, seem to do well. So
Yeah, and the
obviously,
fewer, like I said, the fewer the surgeries that they've had, the better they do.
yeah.
I always used to say to young surgeons that would come to our courses, um, the best patient for you to start out with is a rheumatoid patient because number one, they don't have the TMJ overlay, and number two, they're used to having joints replaced. Okay,
Yeah.
and they do really well. And like the idiopathic condylar resorption patients, every one of them did extremely well because they hadn't had all the other stuff done to them. So
And often they don't have pain. And I think that just reiterates the point of like it's just so baffling to me in the world of TMJ, especially in the, coming from a dental background, is we're so okay with patients being in pain and having limited function, but we're somehow like not okay with them having a couple of little incision sites and a 2% or less chance of
because
facial nerve
because
injury. Like,
people are scared about being painful after the fact. Like
yeah.
they're honestly, that is the reason from what I gather, talking to people, talking to referring docs, talking to patients, is that their primary concern is that they go through the operation and they're worse, right? Because that is bad.
Oh,
And
that's
that
the worst
speaks to
case
how it
scenario.
was in the 80s. So I mean, I think it's still there. What do you think, Lou? What keeps us from making those mistakes? You said history repeats itself. We're all a bunch of surgeons wanting to do well. None of us know the absolute truth. What can we How's it going to help us?
Yeah, well, again, it goes back to people doing this type of surgery ought to be people who do it a lot. And the patients who end up with post joint replacement pain are typically patients who have been misdiagnosed ahead of time. These are the patients who have had multiple surgeries that had, typically have had an extra articular condition that's been operated on the joint instead of dealing with the muscle pain problem. The second issue is the occasional surgeon. I call them the onesie twosie. Um, they, you wouldn't believe. Here we have a custom joint, and when I see what people, the mistakes people make putting this custom device in, it blows my mind.
Yeah, we
Uh,
just did an episode on that. We just talked about like common troubles that you run into. I don't know. I think I'm impressed by how much I've learned by just doing this for enough time. And I by no means have the same volume that you do, but I probably put about 15, 20 patients through this every year. And so my number of devices might be a couple hundred. It's so much better than my initial ones. Not that I was doing a terrible job, but there's some nuance with this.
yeah,
It is,
there are a few nuances, but not nearly the nuances that are involved with a stock device.
yeah. Oh, yeah. I agree with that.
I mean, you
Right.
got to make it fit. I mean, this thing supposedly fits. But I
Yeah.
mean, I've seen these devices upside down and backwards.
No
I mean,
way.
I've seen it. I've seen that too,
way.
actually.
It, I mean, I've seen them where the
Let me just watch
condyle
this patient.
is posterior to the posterior lip. I mean, how does that happen? I mean, it just it's bizarre. Uh, so
Huh.
so the big thing is if you do a lot of them, you're going to have fewer complications. And you do them for the right reason, you're going to have fewer complications. And where are we going to go in the future with all this?
Yeah. We're
Um,
I am concerned about us making the same mistakes. Once we have the people that are retired that have been through this, like the Lou's of the world, the Peter Quinn's of the world. Once you're kind of not sending emails out to us, how are we going to keep ourselves on the track? You know what I mean? Because we are dentists. There's a discrepancy between dentistry and medicine. So how do we bridge it?
I'm really afraid of what's happening here. And I'm going to go on a soapbox a little bit here, but
Sounds
Please.
great.
Yeah, do
what
it.
I'm I'm concerned about um, the way we are training residents. Um, it appears to me in talking to my colleagues that a lot of these residents that are coming through are basically interested in tin and teeth, and that's about it. They don't want to do major type surgery. I don't want to paint everybody with the same brush, but I'm hearing that from an awful lot of people. Second thing that bothers me is that our attendings and our program chairman um, are don't have enough time to do research. They're spending more time on service. They have to. They got to pay the bills. We've got these companies that are buying up practices. They're buying up not only private practices, but they're buying up academic practices. Um, you got to push, you got to make money. You don't have time. I mean, I was lucky when I was at the Medical College of Virginia, I had one full day dedicated to research. My chairman said, you're not to go to the clinic, you're not to go to the office, you're to be, doing research. What program does that now? I can't even think of one. Um, so that's an issue. And you just have to look at our literature. Our literature is how many US programs are publishing in our literature. Most of our literature is coming from outside our country. So I'm really concerned about that, and you make a very good point. I don't know. I was just talking to somebody the other day, one of the trustees for Amos. Um, who's going to take up the mantle, not only of TMJ replacement, but of orthognathic surgery? Who's going to take up the mantle for all the other things that we do? Yeah, there are going to be always people doing dental implants. I mean, because that's my old boss used to say, the Mercedes is behind the second molar. Um, you know,
I like that.
um, you know, I don't know. I don't know where we're going to go. I can tell you where I think we're going to go with these joints, but
Do you think international, they got some good devices brewing out there? Because that's where all the innovation is going to come from in terms of
yeah,
device.
right now there are 40 devices being made in 20 countries,
Yeah.
um, and about a third of them are being 3D printed. Um, we are doing a big orthopedic and TMJ device study at Rush, looking at 3D printed devices. I can tell you that it's real easy to 3D print plastic. It's really difficult to 3D print metal. Um, we don't really understand the crystal structure that's being that occurs as that uh, laser goes across the pattern and fuses the powder. At one area it's hot, another area it's cool, and so we don't get the right kind of crystal formation. We wrote a paper on this, a couple papers on this already. So what we're doing is we're trying to get devices from other countries so that we can put them through our research protocol, so we can look at them under EBSD and some of the other spectroscopy that we use. And what we found with the devices that we've gotten, particularly the 3D printed ones, is that they're terrible.
Hmm.
They break very easily because the
Really?
beauty of 3D printing, supposedly, is you develop more porosity. Well, as you develop more porosity, you weaken the device. So porosity is good on one hand because you get more osseointegration, but on the other hand, as soon as you load it, it breaks. And so we have devices that are broken. We have orthopedic devices that are broken.
Yeah,
Uh,
because the orthopedics are doing that. Yeah. Like
oh
they're
yeah,
doing that to some extent.
spinal cages, acetabular cups are being 3D printed.
How's it going?
We've gotten a couple acetabular cups that are broken. We've had a few cages, spinal cages that are broken. One one came from one of our surgeons. As he was putting it in, it broke.
Oh, wow.
So fortunately, it broke then, and not when the patient stood up.
Yeah,
Um,
in orthognathic surgery world, 3D printing of metal implants seems to be what everyone assumes to be the best, and literature is catching up to that. The higher rates of those needing to be removed. I'm of the opinion there's higher rates of non-union that may not solve all your problems with repositioning errors, those sort of things. Which, from an outsider's perspective, printing metal makes a ton of sense. But what you're describing, which is, the real world might be disagreeing with you in some ways you don't really know until you do the research. Seems like we're kind of just doing it before we do the research.
yeah, and that was my point with the TMJ. One of the arguments that against me my whole career has been, um, why did you start putting these in patients before you put them in animals? Well, we had a need. Okay, one of the reasons for developing devices, be they anything that you stick in the body, is there's a need there. And if you do appropriate studies of that material, and that's why we decided to use the same materials that are used in orthopedics. Um, so we knew that the materials were good. We knew that the design was going to work. And we knew that the manufacturing process, the CAD/CAM process worked. So once you have those embodiment elements correct, then the device should work. And doing it in animals, at that point in time, back in the 1990s, when we started this, um, seemed inappropriate. Because what do? You wait 10 years and let the patients who have all these problems wait for 10 years to all these Proplast Teflon patients. What are they going to? Because we knew you couldn't put a rib graft in these people because the foreign body giant cell reaction ate up the rib graft. So you had to have some metal and plastic device. So research is the key, and I'd love to see more people interested in it, and I just don't see it.
You're speaking our language. There's some of our listeners that are into this stuff. They just, fostering the community and getting us connected. I think that's some of the beauty of, the internet and the different groups that are out there. So, well, one of the goals of us talking about these things, which we, again, totally appreciate you joining us, is to kind of continue those conversations so that we can develop a better network of people. Because, I mean, guys coming out of residency, guys coming out of fellowship, ladies finishing up, and it can be isolating and it's hard to do these cases. And it can be, you know, scary to ask questions of your mentor. So asking questions of other surgeons around you and those sort of things, because we're all here to help each other out. And so, I mean, I've taken a lot of your advice to heart. So I appreciate you sharing it with us.
Sure.
Can I
Yeah, I feel like we could talk to you for hours.
totally
We may have to have you back on. Like,
can I pick your brain on one little some
Sure.
topic real quick? What do you think about taking coronoids? Pro, con? Should I do
great,
it in
great question.
counterclockwise rotation? Should I always do it? Give me your feeling on that topic.
Okay. When I started out, when we started doing this, I did coronoidectomies on everybody.
Yeah.
Everybody got a coronoidectomy. What was happening was I'm starting to see, particularly in bilateral cases, I'm starting to see, I'd go the next morning, take the pressure dressing off and have the patient open and they dislocate.
Yeah, they can't close. Yeah.
That they can't close. So, I'm in the I never had to take anybody back to the operating room, thank God. Um, Put patients through a little bit of hell, relocating them in their bed. But and then I got to thinking, it's probably not necessary to do it in everybody. So I stopped doing it. And then I also realized in my ankylosis cases, at that time I was doing two-stage ankylosis because we didn't have VSP. And I couldn't do it as a one stage like people are doing now. So I would do the condyle and the coronoid at the same time, at the first stage, and then put the silastic block in and then come back 6 weeks later and put the joint in. What I found there was that enough fibrous connective tissue had formed around the coronoid area that I wasn't getting a good MIO. So I stopped doing that. I don't know how many people are doing two-stage anymore. I don't think there are, but I stopped doing it there. And the only other time I would do coronoids would be if I was like an idiopathic condylar resorption that had been there for a long time, or a stage 4 uh, osteoarthritis where the mandible had shifted so much that the condyle, as you lose posterior vertical height due to the condyle going away, you increase the coronoid process because you get a pull of the temporalis muscle. And so when you reposition the mandible on the model, you can see that the coronoid process now sits behind the zygoma. And if you open it, it's going to hit the posterior body of the zygoma. So those people got a coronoidectomy. So what I've recommended now is not doing coronoidectomy on patients. If you do a coronoidectomy, particularly a bilateral coronoidectomy, I put the patients in training elastics for a week. And some people are putting them in fixation. I don't think that's necessary. But put them in the training elastics for a week. By that time, you get enough fibrous tissue developing around the joint that it's not an issue.
Sure.
So that's a long answer to your question.
No, I like
A
long
lot of
answers.
parameters there.
I get in the weeds pretty easy, so I appreciate that. I like that one. Wasson, you got any more?
Oh, you kind of almost opened a can of worms, but we're already running a little long here. I mean, I'm sincere when I say that I think we should, you know, scheduling permitting and your willingness, Lou, we'd love to have you back on because I feel like we haven't even hit on like half the stuff that we could um,
But
with you. But you know, your wealth of knowledge, which is usually lacking when it's just Sam and I, it's just usually nonsense.
yeah,
So
no, no, it's great. Yeah, no, we really appreciate you coming on and sending the emails out. I mean, I can speak to, and I don't know everybody on that email group, but the people that I know, it's really a crucial resource. It really is helpful. So,
Well, good. I'm glad that so people I send out that every so often I ask, if you want to be removed from the list, please let me know.
yeah.
Um, this week I got one.
Oh,
really,
wow.
Yeah, he said he's retiring from practice and he's he's going to go off into the sunset. So I guess he doesn't want to see these
Has
anymore. That's fine. That's great.
has that volume of people kind of leveled out to support
Uh,
your concern about the youngsters not doing as much surgery?
yeah, it's we're up to about 200 people on that thing
Yeah,
now.
that's pretty good.
I'm waiting for Google to tell me I got or Microsoft, whoever it is that I use to say I've got a limit.
Oh yeah.
I'm gonna have to knock some people off.
You get rid of Wasson. You don't read anything.
yeah, yeah, you get rid of me. I mean, it's probably over half my reading that I do. You know, like it's I peruse our journals and read a couple things in those, and then I pretty much I skim everything. Having the summaries that you provide is amazing because it just makes it so much easier to know what I actually want to read more in depth on. But yeah, I utilize it
Can I
frequently.
have one more question I wanted to ask you.
Sure.
So if you're a patient, let's say, or if you're a provider that doesn't know as much about this, let's say you're in oral medicine or, in dentistry, and you wanted to find a resource online that was as unbiased as you could go. So maybe not tmj.org, maybe not striker.com. Um, where would you go?
That's a good question. Um,
Literature?
it's
Do
right
people
off the
just,
top of my head. I was going to say, you can go to FDA and type in TMJ replacement. Um,
because,
they have a whole bunch of stuff.
people just ask AI or, whatever the
Yeah, AI.
language model is, but to get data on it, is there a direction generally? Does the FDA have pretty good resource to kind of review this stuff or
Yeah, I mean, I look at that every so often just to see what they have to say, but it's very generic.
yeah.
They talk about the devices, and they have a very generic thing about the devices. They don't really go into all the history and all that stuff. Um, I guess the best thing to do is you know um, go to PubMed and type in TMJ replacement, and you'll come up with a whole bunch of papers.
Yeah.
Uh, I mean, that might be the best thing because that's part of the most unbiased source that
Yeah,
you
I've
can
been wanting the gatekeeping on the journals to go away so that people can just access it, right? I mean, it's 35 bucks an article. It's crazy. So
find.
whenever that gets solved, that'd be great. Because I mean, I think the literature really does support this. I think the things we hear about, it's still unknown. We still don't really know what's the right approach. While that's somewhat true in general, particularly in the bad situations, the devices that exist, and particularly the device you help develop, is a great device. So, thanks a lot for all of that.
Yeah, I would echo this. I mean, just in case there are people outside of our specialty and our wheelhouse listening, I always like to put the plug in for the literature does show pretty convincingly for actual articular or intra-articular disorders, and I like the new term IPD, the intra-articular pain and dysfunction that I think have come out of the blue papers recently. I like that terminology better than the internal derangements that tend to try to keep it all with a disc fossa relationship classification and Wilks and all that. I kind of like the IPD terminology. The literature's been pretty clear that surgery is superior in outcomes to non-surgery. Now, that doesn't, in my opinion, mean you shouldn't try some non-surgical stuff first, but if you're going off of outcomes of higher pain relief, better function, faster pain relief, faster return to function, minimally invasive surgery, and just surgery in general gives you the better outcomes. But yet we're still kind of put that on the back burner. And like it's weird that we don't talk to patients about the best option. It's like if I was the patient, I would want to know, hey, surgery gives me the best results, but there are alternative options, and then I get to choose what I want. But it's weird that we don't do that in the surgery world. So I always just like to throw that out there. But I don't know if you guys have thoughts on that or if you just want to wrap it up.
Well, I just say one more thing on that issue. We're working on a paper with that kind of discusses that. When should a patient be referred to a surgeon who has temporomandibular joint dysfunction? Okay. And you'd think that would be a fairly simple thing
Should be.
but it isn't. It isn't. There are so many variables. That's why I say we're working on it. But there's a lot involved in that. But you make a very good point, and we'll see. We'll see what we come up with, and we'll get it out there. But what I would
Yeah.
like to do sometime, if you're interested, is discuss internal derangement and how we got
We'd
hung
love
up
to.
on that, and why we need to get unhung on that.
Yeah, I think contrary to how Sam's dating life went, I don't think we would ever tell you no, Lou. If you wanted to come back on, we would always say yes.
I'm trying to follow that one.
But I mean, it is
Probably some
remarkable, and
pictures.
I think one of the biggest hurdles we face, and maybe this is a topic for the next time, is kind of having a better relationship with the oral facial pain specialists, because they should be the gatekeepers to all of this. But I find that that's with some exceptions, and again, to use you guys' nice old man saying from earlier, we don't want to paint everyone with the same brush or paint everyone into a corner, but like I find that those are some of the people who are the most anti-surgery, and they're supposed to be the specialists,
Yeah.
and
And
the knowledge gatekeepers.
the other group are physical therapists.
I find it less with physical therapists. I have a
PT,
number of physical
young
therapists
PTs are pro.
Oh, good.
Yeah,
because I
that's
think
changing.
they see it in other joints, similar to what you were saying, Lou, in the orthopedic approach of why is this joint somehow different than every other single joint in the body? And I find that physical therapists are actually, in my life, have been some of the better ones.
Good. Good.
Yeah,
I've been working with a physical therapist here and on a few ideas, and she's very involved with the national. Oh God. Anyway,
Yeah.
um, involved at a higher level than I am with this stuff, but on the PT side. But yeah, let's talk about maybe we can do something on internal derangement.
let's
I've got
do
a
it.
lot to say on internal derangement.
All right.
Sounds good.
These are my 800 cases that failed.
Yeah, I mean, I think my experience kind of sounds similar to yours. Well, we'll end it there because our audience has the attention span of like a 2-year-old. So we'll end it there. But thanks again so much for coming on because I mean, you have a perspective and a knowledge base that really is not something that can be replicated. And so I think having you on and hearing your story and for those out there who get to hear it, I think that's invaluable. So thanks again for coming on. Thanks for giving us your time. That was another Down Fracture podcast, a podcast for talking jaws, downfracturepodcast at gmail.com. And thanks again for listening.
All right.